Hello. Thanks very much, everyone who has joined us today. It's very exciting to, for the first time, be speaking with Dr. Francine Johansson Azaredo. She's from the University of Florida College of Pharmacy. She's an associate professor at the College of Pharmacy. Her areas of research include translational modeling, pharmacokinetic, pharmacodynamics modeling, as well as precision modeling. She has interests in areas such as model-informed precision dosing and therapeutic drug monitoring, and has worked on several research projects, both in the US and in Brazil. She is today joining us to talk about one of the areas that is really of interest. We have a bit of work going on in Uganda on therapeutic drug monitoring, but the question of how pharmacometrics can actually provide meaningful impact in therapeutic drug monitoring is, I think, on a lot of people's heads. And we are very excited to
Sorry, Francis, you seem to have muted yourself.
Okay.
We can hear you now. Thank you.
Okay, so I'll go again. I didn't realize I was on mute. So welcome everyone who has joined the call today. We are very excited to be having Dr. Azaredo from the University of Florida College of Pharmacy. Her field of expertise is on translational PK/PD modeling, specifically on areas such as model-informed precision dosing and other areas to do with the translational PK/PD analysis, as well as therapeutic drug monitoring. She has done a lot of research both in the US and in Brazil, and we are really grateful to have you today to share with us your vast knowledge and experience on this field, which is of interest a lot, I know, in Uganda, but also in several African countries. We'll be hearing more on how pharmacometrics can contribute towards optimal therapeutic drug monitoring studies. So, Dr. Azaredo, I'll request you to share your slides, and after that, we can dive into the presentation. Thank you. I'll hand over to you for now.
Okay. Thank you so much, Francis, and all the Pharmacometrics Africa Uganda chapter for inviting me for this seminar. And it is my pleasure to be here with you guys today. So as Francis said, in this lecture today, I will be talking about the use of pharmacometrics for smarter therapeutic drug monitoring, TDM, in resources limit settings. But first, I will present myself a little bit. I do know that Francis already presented my research interest areas, but I'll talk a bit about who I am and where I am right now. So I'm Francine Azaredo. I'm a Brazilian. So I did my BS in pharmacy and my PhD in pharmaceutical science from the same university of Federal University of Rio Grande do Sul in south of Brazil. And during my PhD, I came here at the University of Florida, and I did a period of studies under the supervision of Dr. Hartmut Derendorf back then. After that, I did a postdoctoral at the Federal University of Rio Grande do Norte. Then I moved from southeast to northeast of Brazil. And I was able to continue working with Dr. Hartmut in a Brazil-US kind of partnership that we had back then. Then I started as an assistant professor at the Federal University of Bahia, also in northeast of Brazil. And during my period there, my tenure at the Federal University of Bahia, I could start the first research lab on pharmacokinetic modeling and pharmacometrics in northeast of Brazil. So I was very proud of that. And I was able to supervise more than 5 master students and 2 PhD students who are still working in the pharmacometrics field, which I am very proud of that. So at the end of 2021, I started here at the University of Florida as research assistant professor, and I'm back to the Gator Nation, but then the only difference that we are located in Lake Nona in Orlando and not in Gainesville, as when I was a PhD student, I lived for almost a year. So my main works, and you guys will see because I'll present a lot of results in the anti-infectives area. So this is my main research interest. So it's in anti-infectives and also for drugs to treat neglected disease as malaria and leishmaniasis. I've been doing a lot of work, but more in the translational part and not on the therapeutic drug monitoring. So I won't be showing that results today. So today we are going to talk about a little bit about the precision medicine, the therapeutic drug monitoring, its challenges and how it should be done, and some challenges that we face in countries with resources limited as Brazil. And I'll bring the modeling informed drug development and modeling informed precision dosing as tools for us to use with more clever, I would say, the data that we get from TDM. And then I'll bring some populational PK/PD in antifungal, antibiotics, and in mood stabilizer that it's been my latest works on the field for us to discuss after that. So regarding precision medicine, we do have been a lot of discussions, and let me just, yep. So we have been having a lot of discussions in the precision medicine field, where we should be working more with the informations that we have in order to get a better result when we are dealing with patients. So in the precision medicine ecosystem itself, we use genomic, molecular, and other informations to individualize the treatment strategies. So this, it's focused on, of course, the record that we clinician has access to from the patient. It can also work with patient samples and biobank, and then it's going to take into account the genomics of the patients, the phenotypes, the outcomes that we are going to have, what is the family and medical history of these patients, and then we are having a research-derived data. So the action that the clinician will take will be on the research database and research-derived. So this is something that we are going to have, of course, the back team working on that as the clinical laboratory, and also the researcher that it's going to make this research search in the database. And it should be also available with some results to other institutions. So this is like the main goal of the precision medicine. So it is to deliver the right treatment to the right patient. So as I said, the precision medicine uses genomic, molecular, and clinical data to guide these individualized treatment strategies. Of course, focuses more on predicting disease risk. So one of the things on the precision medicine that we are seeing more and more, it's related to some genes that can be related to breast cancer, for instance, and of course the drug response and the treatment outcomes. So as I said, in my example on the breast cancer, so it is applied more in fields like oncology, some infectious disease, cardiology, and neuropsychiatry. And we are going here, it's to include the pharmacogenomics, the biomarkers, and the modeling, the computational modeling here. And now what we are doing more, it's like instead of proacting, we are going to instead of just reacting, we are going to be more proactive and search for the information that we know that can change here the disease risks and the treatment outcome. of our patients. So precision medicine is one of the things, but if you you can see here that I did not say anything about the quantification of the drug in our patients. So we do not work with that here for precision medicine. It's more related to the knowledge that we have on the genomic and the clinical data that we do know regarding our patients in order to choose the best treatment here. But there is something that comes after that. So once the patients start its treatment with the desired drug or the chosen drug by the clinical, we do need to also have another important factor here on the treatment, that it's the therapeutic drug monitoring. So the therapeutic drug monitoring, it will involve measuring the drug concentrations in the patients in order for us to ensure safe and effective dosing. So the first thing is we need to identify the patients appropriate for TDM. So this is a picture taken from a manuscript published on anti-infective fields. So this is why you have it here, the number 2, the MIC, but let's not pay attention into that right now. So first, we need to identify the patients that it's appropriate for the therapeutic drug monitoring. So it won't be all the patients that are going to use this TDM in the right way, right? Or in a good way. So we need to have the drug exposure target very well defined. So we need to know if let's say the concentration range that we have the effect, and we start also having the toxicity sides. So this is something that it's important. We need to know this. If we have any PD target, it's also something that will be very available for the therapeutic drug monitoring itself. And the other thing is, does this drug has a high risk of toxicity? So this is another thing that it's important for us when we identify which patients we should use, we should perform the TDM, right? So once we have done that and we have the drug exposure targets well defined, so for instance, for anti-infective will be the MIC, the toxicity of these anti-infectives, and then we'll know that. If it's another kind of drugs, I'll explain to you a bit more on the anti-infective fields and targets, and also on the mood stabilizer. So take the sample early in therapy. So it will be as soon as you can, you need to take the sample from the patient. Usually, where do we take this sample? We do take from the central compartment, right? So it's we'll quantify the drug in the blood, in the serum, in the plasma. So this is what we usually work in real life. Then we have the best way, right? It will be to have the results on the same day. The clinical can interpret the results, right? So consider using some software simulation, if we do have, to simulate what will be the concentrations in the patients after a number of dosings, or when the patient will be in the steady state. Adjust the drug prescription and then recheck the concentration of the drug. So this will be I would say, the best case scenario for TDM, right? So you do have that clinical team with physicians, pharmacometricians, with the pharmaceutical, clinical pharmaceutical, and of course, the laboratory that it's going to quantify these drugs, all working together and in a fast way. So it'll be easier to make any adjustment possible in the patient right away, right? So this is what we really want to have in a hospital or in a clinical care. So for optimize the drug therapy for using therapeutic drug monitoring, as I said, so we do, it does involve measuring the drug concentration in blood or plasma to ensure the safe and effective dosing. This is essential for drugs with a therapeutic index. I'll give you some examples today. It also helps to avoid toxicity and subtherapeutic levels. And this is mainly true with patients that we have variable metabolism or even the renal clearance here. We are going to adjust the dose based on the individual pharmacokinetic profile. So this is something that it's really important. No? We are not taking into account the mean PK values or that pharmacokinetic values that we see in the label that it's on healthy volunteers. So here we are working with the real PK parameters on our patients, and also connecting it with the PD profiles when possible. And here, what we are doing, it's the TDM is something that it's integral to the precision medicine. This is what I would like to say to you guys. So this is it's a step that it's really important, and it will for sure improve the clinical outcomes of our patients. So, but we do have some challenges on TDM in countries like Brazil. That it's all the works that I'll show you guys will be with values from Brazilian patients. So I'm sure that it's not only in Brazil, right? We do have that in many different countries. So we have limited infrastructure. So I would say that at least that I am aware of, we do have very few hospitals that use TDM as I presented on that picture, like as it should. So this is due mostly because we do not have accredited TDM laboratories in our hospitals. The inconsistent access to analytical platforms, so the HPLC, the LCMS-MS. LCMS-MS is really inexpensive, and few places have that in Brazil, but even the HPLC, it's also a hard thing to have in some hospitals, mainly in the northeast of Brazil. We have a high cost of assays, and this also limits the routine use of TDM. We have unequal access across regions and healthcare systems. So even though we do have the unique health system for the whole country, I would say that the facilities are not the same when we go for places like São Paulo, for instance, and that we have better hospitals and much more access to new technologies than if we are if our patients lives in Central West or in other Middle West or Northeast of Brazil. Also, we do have the lack of standardization. So this is something that it's really hard when talking to all the team, like so the nurses in the sampling timing. So sometimes they do not take the correct they do not put like in the note on the correct time that they did the sampling. So then we have the sampling and it doesn't fit where it's supposed to be. So this is something that it's really hard, because in PK, one of the things that we should be sure of is the time sampling, right? That we are doing. Also, people to interpret and report this kind of data. We have limited integration of TDM into the clinical decision making. This is another thing. So physicians and our medical doctors, sometimes it's a bit hard for us to explain to them what a great interpretation of TDM could give them. So why we should do that in that stepwise approach. And this is something that it's really, really important. And sometimes they also do not take into account only the PK value to make that clinical decision making. So this is a change of mind that we need to have in the medical population, at least in Brazil. We for sure have the workforce and training gaps. We do know that pharmacologists, pharmacists, the pharmacometricians, they need to be well trained in our software resources, and also in how to interpret what the model is giving to them. And as I said, the limited awareness of TDM among healthcare professionals. This is something that it's really lacking, and it's important for us to have more. And we have the data and population specific guidance. So Brazil, it's a huge country. We have a lot of difference as in genetics. So we do not have that much of pharmacogenetic data on our population. And if so, we do have difference regarding the regions that we are dealing with. So south of Brazil, we have it's a different genetic population if we compare, for instance, with north of Brazil or with the Amazon region. So this is something that it's really lacking, and it's important for us to have more region-specific data also in genomics. And for sure, the reliance on international guidelines. So it's not tailored for our local populations. So one I would say that some of these challenges here that we have in using properly the therapeutic drug monitoring in Brazil can be solved, or at least can be better used when we use the modeling informed, right? Drug development or modeling informed precision dosing. So first I'll talk a bit from the modeling form drug development as a whole thing, as a technical tool. So we do have that from practical standpoint of view, the MIDD will involve the development and the application of the exposure-based biological and pharmacological models, right? So we do have some preclinical and clinical data source, and then we are going to address the points in the drug development and in the regulatory issues. So this is something that we are we do know well that MIDD can be used during this drug development and the regulatory issues. But I would like to discuss a bit about what are these soup of letters that we do have here, like PK, POPPK, PBPK, and how this can help us in the patient care, right? So MIDD, it's used for application of exposure-based biological and pharmacological models, as I said, right? We do have a lot of different approaches here that are considered modeling form drug development. So we do have the pharmacokinetics, the PK model as the classical one, the populational pharmacokinetics, and the physiological-based pharmacokinetic model, so the PBPK. So it's only taking into account the drug concentrations, right? So here we are having drug concentrations, and of course, physiological and other covariates that we might have that will explain the exposure of the drug in the particular patient. Once we start adding the PD, the pharmacodynamic here into the account, so now we are talking about PK-PD model, then we are going to add the response, right? So we do know the PK, the exposure part, and then we are adding here the response part. And of course, we do have other kind of models that will model the disease itself, or that we are going to use MIDD to predict some clinical trial models. So what is the dose that we should do, and these other things. We also have the systems biology, the quantitative systems pharmacology, like the QSP. And another ways that we are now seeing here, we are adding the disease into, we are having the disease into consideration here. And sure, we do have that classical ones, the XR, that it's the quantitative structure activity relationship and the structure property relationship. This is related to the chemical, to the drug itself, right? So this is all MIDD. We do know that MIDD is being used now for many years in the drug developing and the regulatory issues, but we are seeing more and more disuse here of MIDD. So modernize new drug development and also the patient care, and also reshape policy development. So when we are talking about using MIDD to improve and to modernize patient care, we are talking about the model-informed precision dosing. So now what we are doing here, we are taking into account the clinical characteristics of our patients, the dosing history, of course, for the drug that it's using, all the values that we have from the drug being quantified in the lab, and biomarkers that can guide us in getting that PD profile. We will do a model-based Bayesian forecasting. Most of all, we can use other ways of modeling this. Then we will understand the individual PK and PD profile and determine optimal dosing regimens. So this is what we say that it's the model-informed precision dosing. So now I'll give you some examples of drugs that I've been working with, and I will start with the antibiotics. So in order to explain you better the use of pharmacometrics and this model-informed precision dosing in the antibiotics field, or in the anti-infective fields as general, I'll have to explain first the PK/PD index of anti-infective drugs. So these PK/PD indexes, what they will do is they will guide the drug posology of the anti-infectives in general, right? So we do have two different categories that we can say that an anti-infective is. So this drug can be concentration dependent or time dependent, right? And for these two different categories of anti-infective drugs, we do have three PK/PD indexes that will be used in order to estimate and to recalculate the optimal dosing regimen of these drugs. So we will have the first PK/PD index will be the Cmax over MIC. So let's talk about what is MIC. So MIC is the minimal inhibitory concentration of a drug against a bug. And this is something that it's done in vitro, and it's like a twofold concentrations that we use for these microbiologists used in order to estimate the better MIC. So let's say, for instance, we'll put 0.25, 0.5, 1, 2, and 4 milligrams per liter of a drug into an inoculum containing some bug, and then we will count we will just see the bug growing in this medium. So when it stops growing, then we'll say that the MIC is this. Let's say that we do have some growing in 0.5 concentration, but we don't in 1 milligram per liter. Then this 1 milligram per liter is the MIC of this particular drug against this bug. Okay, so this is the PD part of anti-infectives that we use. So it's the MIC values. And regarding the PK, so this is the Cmax. And usually what we work, it's with as I said, with the concentration in plasma or in blood or in serum, depending on the drug. So we are taking into account here the maximum concentration that we have after administering this drug of the patient. So we use this value of Cmax, we just divide by the MIC, and then we'll give a PK/PD index of a concentration-dependent drug. The other PK/PD index, it's time above MIC. So what is this time above MIC? It's the time that the concentration in the central compartment, so in plasma or in blood, so it stays above the MIC. So now what it's important for me here, it's that I keep this concentration higher than MIC for as long as possible. And this PK/PD index is the one that we do use to estimate the posology of drugs that are considered time dependent. And then we have AUC over MIC. AUC, we are seeing here the area under the curve for 24 hours. And now it's related to exposure. So both drugs, concentration dependent and time dependent, can have this PK/PD index as rolling its posology, okay? So this is the indexes that we do use, and I'm going to show you in order to estimate better drug regimens for the drug. So the first case that I'll be presenting, it's related to methicillin-resistant Staphylococcus aureus infection, so MRSA infection. MRSA, it's a major cause of drug-resistant infections in both hospitals and community settings. And I will present here the results that we have in the therapeutic drug monitoring of vancomycin in these patients. So vancomycin is a glycopeptide, and it treats serious MRSA infection. So for endocarditis, for pneumonia, skin or soft tissues infected. So it works by inhibiting the bacterial cell wall synthesis, so it leads to cell death. Why this is important? Because this is another thing that we have in the anti-infectives. If this drug is bactericidal, as is the case, it leads to cell death. We can model its PD in a different way, that if it's a bacteriostatic drug that just inhibits the growth of the bug, okay? So when we are using vancomycin, we do use it as intravenous administration, mostly. And the dosing, as I said, it's guided by the AUC over MIC base monitoring. So the PK/PD index of this drug, of vancomycin, is AUC over MIC. So it has to reach a certain value for us to maximize the efficacy of these drugs and minimizing the risk of nephrotoxicity. So vancomycin has a narrow therapeutic index and has some important toxicity side effects, right? As nephrotoxicity, as I put it here, ototoxicity also. And this work was done in neonates and infants. So this is these patients were in a neonatal intensive care unit located in Salvador, Bahia in Brazil, so in northeast of Brazil. And the vancomycin was given as 10 or 15 milligrams per kilogram IV into this patient. So for each patient, they took three blood samples. So it was considered a TDM. So it was just, these blood samples were after the dosing, just before the second dosing, and between them. Okay, so the creatinine clearance for these patients was estimated by the Schwartz equation. So, of course, because these are neonates and infants. So we do have some patients with 11 days from until 111 days. So here we are working with really young patients. And this is just like the overall results that they have from serum creatinine values, the vancomycin clearance, and the creatinine clearance that was estimated using the Schwartz equation on these patients. And then what we did here with these values is this was a study performed by the clinical pharmacist in this hospital. So she was there the whole time with the patients and getting the time point values, which is something that it's really important. So what we did is with these 3 different samples, we get the values of vancomycin, of course, in the TDM, and this is all the values that we have from trough target. So it should be from 10 to 20 milligram per liter in infants. So you can see here that some of our patients are above and some are below these values. And what we did here is we got the AUC of the patients before the adjustment. So the AUC was estimated using these 3 concentration values here. And we used the target AUC, as I said. So for vancomycin, what is our PK/PD target? It's AUC over MIC should be equal or higher to 400. So we did use different MIC values for these MRSA strains that we were working on, and then we made the dosing adjustment here for the patients related on that. So she estimated more. So if you can see here, the results that we've been showing are more in tables. These are the way that she was able to show the clinicians and the medical doctors in that particular hospital, so that they can better understand, and they did perform the dosing, the new dosing regimen that was done after this PK/PD modeling here of these values. So in this case, we did not perform any populational PK/PD, was only the NCA for the AUC, and we were relating that to the MICs that we knew the values in order to improve this ratio here and make the number of doses smaller for this patient. So we optimize the number of dosing in these neonates mostly and infants. The second example that I'll be showing you, it's related to amicacin. So amicacin is also an antibiotic. So it's a broad-spectrum aminoglycoside antibiotic to treat gram-negative bacterial infections. So here we are talking about Pseudomonas aeruginosa, Enterobactericisia, among others. So it's also used for multi-drug resistant strains and hospital-acquired infections. So amicacin can be administered intravenous or intramuscularly, and it does act by inhibiting the bacterial protein synthesis. So now what I'm doing here is I'm inhibiting the bacterial growth, right? And it does require the therapeutic drug monitoring, so we can optimize the efficacy and also avoid nephrotoxicity and ototoxicity that we see in amicacin. And what it's usually used is to treat sepsis, pneumonia, some intra-abdominal and urinary tract infections. So in this result here, in this work, we worked with patients from Santa Maria. Now I'm going to south of Brazil, and it's at a teaching hospital there. So we had 39 patients, and we have dosing ranging from 225 milligrams to 1,500 milligrams, and also administered twice a day, once a day, or every 2 or every 3 days. So here we worked with 113 amicacin concentrations, so both peak and trough, okay? So you can see here that this drug was used to against different bugs. So we do have, of course, more for Klebsiella here, but we have also for Pseudomonas, Acinetobacter baumannii, and other bug strains here. So most of our patients were male. We had 33 male and 6 female. We do have ranging the age. So if you See here we have from 4 years old to 75 years old, so 2 pediatrics, 28 adults, and 9 elderly, right? Also the weight and the BMI, it's ranging a lot as the serum creatinine and the creatinine clearance that was estimated using Crocov-Gault. So now for this result, we did perform a populational PK. So we did have information on a lot of covariates that we could use. And then we performed this populational PK, pop PK here, that will give us a better value, right? So what we used a one compartment body model, and we did had as a covariate the creatinine clearance on the amikacin clearance itself, right? And we used monolix here for this modeling. So once we have the populational PK results model, what we did, we simulate 500 patients, and we used the PK/PD index of amikacin as a target attainment. So we did here, it's the PTA, the probability of target attainment. And what are you seeing here? So as I said, we are estimated 500 patients for each different dosing regimen. And the target for amikacin is the PK/PD index Cmax over MIC should be equal or higher to 8, right? And what you can see here is that for a dose of 500 milligram once a day, we do not see good results in the different MIC values that we have of amikacin against the Klebsiella that we used since was the main bug that we got from the patients. And if once we are getting like this dosing higher, then we are starting to have better outcomes. So I would say that here for the 1 gram once a day, now I do have over 90% of probability of getting the target done, so of success in the MIC over below 16 milligrams per liter. So now I'm talking about resistant drugs more. So this will be like a good drug dose regimen for this drug. And for sure, when we do 2 grams every day, then it's even more successful here, right? So this is something important because if you remember, I said that we had dosing ranging from 225. So this 225 for sure did not reach the target. Now I will show you one example in the antifungal arena. So the disease that we are talking here, it's aspergillosis. So Aspergillus fumigatus is the most common strain that will cause the aspergillosis disease, and its invasive aspergillosis is the most severe one. We do have some it occurs more in immunocompromised patients, for sure. So patients that have cancer, that are under chemotherapy or organ transplantation, or if they have any disease on the immune system. And the symptoms can be like very mild to very severe, and it has a extremely high mortality rate from 40 to 90%. And the treatment, the first choice is voriconazole, amphotericin B, or voriconazole with echinocandins. So the results that I'm showing, it's related to voriconazole. This drug, as I said, it's used for invasive aspergillosis mainly, but also for some serial candida infections. It inhibits some specific esterol enzyme in the fungus, and then disrupts the ergosterol synthesis in the patients. It has a high oral variability in relate that it's like in the literature. Some important hepatic metabolism, mainly in CYP2C19. It's the most the enzyme that does metabolize this drug. It has non-linear PK, so TDM is very well recommended. So we do have some important side effects here. as liver toxicity, KT prolongation. So this is something that it's important. And if we do have some liver impairment, we need to adjust the dose and also monitor for drug interactions. Why? Because it has this CYP2C19 path, very important here for this drug. So in this case, we use populational PK to characterize the voriconazole metabolizer subpopulations in patient without the CYP2C19 genotype data. So now I'm talking about, again, some difficulties that we do have in Brazil. So as I said, we do not have the genomics for all the patients. So it will be important for us to know if our patient is a ultra rapid metabolizer or extensive metabolizer, a poor metabolizer of CYP2C19, but this is something that it's not done in a day-by-day practice. So how can we improve, and how can we get a better dosing regimen for this drug when we do not know what our patient is, right? If it's a slow, an extensive, or ultra rapid metabolizer. So here we have results of voriconazole being administered oral and IV, and in the dose of 200 or 400 twice a day. So what we have is, we do have the data, peak and trough data for all the patients. We performed the, here we are talking about cancer critically ill patients. So we do have the data from the TDM for these patients. We performed the POP-PK model, and then we did the PK simulations. We used the PK/PD index for voriconazole, that it's AUC over MIC should be equal or higher 25 to estimate the probability of target attainment, as I said. And then we can individualize the dose of these patients. Just an overall of the patient's demographics. So here, again, we do have some, we have 25 patients, some children and adolescents, and adults when we did this modeling approach. And we have also this higher range of weight, height, and creatinine clearance values. So you can see here the peak and trough values for each patient ID that we have. And for some of them, we have toxicity values of higher concentrations here that can lead to toxicity of subtherapeutic concentrations that then we won't have an effective result, right? So this POP-PK model was one compartment model, and we use in NOMEM the mixture model kind of approach. So the software NOMEM, they separated the patients in 3 different subpopulations for us: the fast metabolizers, the normal metabolizers, and the slow metabolizers, based on its Vmax values. So for the group 1, that it's the fast metabolizer, we do have a high Vmax value of voriconazole, and for group 3, that is the slow, we do have a lower value of Vmax for voriconazole, right? So the Ka was fixed based in a previous publication, but all else was estimated here. The PK/PD index, as I said, was the AUC over MIC, equal or higher 25. And here we performed different dosing regimens, because we do have these 3 different populations. And here we have like from 4 milligrams per kilogram every twice a day to 12 milligrams per kilogram twice a day IV infusion. And we have 200 milligram per kilogram twice a day, and 400 milligram here, not per kilogram, okay? Milligram and 400 milligram twice a day oral administration. And we can see that for that patients that are considered fast metabolizers, the results are worst for sure for PTA comparing to the others. So it's really important for us when we are talking about voriconazole to know 2 things: the bug that we are treating and its MIC, but also who our patient is. And this model that we did will help in the future because only based on the TDM value that we have from that patient, we can separate it in one of these subpopulations here. So we could characterize the subpopulations based on Vmax, and it was in a distribution very close to one that we have in the Brazilian population polymorphisms available in literature. And the other thing that we can see is that for fast metabolizers, the best way of working is to have a higher dose. Another thing that was important in this project itself is that at the beginning of the project, the clinicians did not give a loading dose of voriconazole. And then we had more than 50% of deaths in our data set. So we just sent to them the first modeling results that at loading dose is something needed. And they started to use that in that specific hospital in Brazil. So last, I'll show you some results on a mood stabilizer drug, lithium. So lithium is used to treat bipolar disorder. And bipolar disorder is a chronic mental health condition. So we have some alternating episodes of mania and depression. Lithium is the first line mood stabilizer to treat these manic and depressive episodes. And it has some effective results in relapse rates. Its therapeutic drug monitoring is essential because the narrow therapeutic index, so we do have the range from 0.6 to 1.2 millimole per liter. We have some common side effects for lithium, so it's very important not to reach higher values than 1.2, like tremor, weight gain, hypothyroidism, and renal dysfunction. And it also requires regular monitoring of renal function. So in this work here, then we are back to Salvador, back to northeast of Brazil. It is I would say the hospital that are correlated to the Federal University of Bahia that we've been working on. We had 28 patients, and we use Crookoff-Gault formula to estimate its creatinine clearance of this patient. So we do have some varying daily dose from 300 to 1200 milligrams per day of lithium in these patients. We have also the age from 26 to 78. Now we are only talking about adults and elderly population here. Some range also in weight and height, and the values of creatinine clearance. This varied a lot, from 40 to 170 milliliter per minute. And also the value of the concentrations of lithium. So it varied from 0.1 to 1.8 millimole per liter. So you see here we have below the minimum concentrations that we need to have the efficacy, and also higher than the minimum that starts having the toxicity issues. So we performed a populational PK analysis using monolix. It was one compartmental. The lithium is administered oral, so we do have the absorption rate here estimated, and the creatinine clearance was a covariate in lithium clearance. So this is something that it's expected since lithium is mainly excreted by kidney. And what we now did, since we are not working with anti-infectives here and we do not have that PD part, we just performed some simulations. I'm showing you guys here a simulation of 600 milligrams twice a day of lithium. So this gives us 1200 milligrams daily dose, and some simulated patients that have different clearance, so we can see the concentrations that we are getting from lithium over time, and the target concentrations being 0.6 millimole per liter, because I do not want to be close to the limit of the dose and then having some toxicity issues. So you can see here that if we have the lower creatinine clearance, we do have high concentrations. And if we have high creatinine clearance, we do have low concentrations here for lithium. So it's must, I would say, very important for us to do estimate the creatinine clearance of our patients before getting the best dosing scenario for lithium in these patients. So as general considerations, I would say that we do have access to laboratories may be limited in some regions, making the traditional TDM challenging or unfeasible. But we can use pharmacometrics to optimize this use of sparse data, support safer and more effective drug therapy. And of course, the emphasis on the MIPD to tailor treatment without frequent sampling. So this is something that it's important. And we can bring population of PK with Bayesian forecasting that can bridge gaps in the routine of TDM infrastructure. And also, it's important to have a capacity building, a training, and collaboration to implement the TDM programs globally. So I would like to thank all the researchers that worked in these 4 different drugs that I showed you guys. And I would like to thank you again for inviting me, and I'm open for questions.
Thank you very much, Francine. I think it is quite extensive and elaborate and a number of learning points. We have time for about 1 or 2 questions, but I'm sure that everyone who has a question can always send it through and via email. I think we should be able to continue the discussion. I'm going to read a question that is on the chat here, anonymous attendee. So the first question is, are there open access resources or training programs tailored for pharmacometric applications in TDM? And the second question is, how sustainable is MIPD in low and middle income countries with the drug stockouts, especially in spaces such as cancer treatment? I'm not sure if you've got these questions correctly, but maybe I can add. Okay, maybe you first respond to this. I have one general question, and then we can continue the discussion via email.
For sure. No, for sure. The first thing, we do have, we have our Shiny that we can use in order to, once we perform all these modeling things, and then we can, it is an open source, and people can simulate different dosings once we have that. So this is something that we do have for voriconazole, if I'm not mistaken. But if we are talking about performing the populational PK before and then getting all these equations and modeling done, you have different softwares that it's not like open access, but it's free for academia, for instance, as Monolix, but we also can do that in Ardor. It's an open access resource in order to model that. If you do not need to perform the population and you can do just based on NCA approaches, then it's even easier, and it can be done using Excel as an open access resource. But of course, using R, it's the best way for doing so. And the second one, I'm not sure if I get like how sustainable is. I would say
it is a bit it's really context specific, because for example, if you take Uganda as a country, sometimes we have actually drug stockouts in the hospitals. So that is the context. So how feasible, how sustainable is MIPD if there's a problem as simple as drug stockouts?
I got it. Thank you, Francis. So then I would say that it's even more challenging. We do have that in some specific cases in Brazil, but not in oncologies as that. So I would say that the best way of working with this is getting the MIPD on that drugs that we have free access most of the time, and if it's the case that if one of these drugs get stockouts and you need to replace, or you cannot use that drug again, you can just redo it, the TDM, based on this new drug. And then I would say use the values that you do have, because we are not working here in that dreamed world, right? We are doing working in real world. So just go for what you have in literature and work with that.
Thanks very much. I'm afraid we won't have more time for discussions. I have a series of questions that I'll send you, and I think this conversation will continue via email.
Okay. But if you want to ask it, for me, it's not a problem. I can stay a bit longer, but I'm not sure. Yeah,
I think a lot of people will drop off soon.
Okay.
But we really appreciate a lot the time and sharing your experiences. I think we've learned a lot, and for sure we'll be discussing this a little bit further.
Yes,
So thank you very
I'll
much.
leave my email in the chat. Please feel free to contact me if you did not get it during the presentation. Okay?
Yeah.
I'm so sorry that I left a few minutes only for the Q&A.
No worries. We'll have another schedule for this. Thanks a lot, and
Thank
have a
you.
good rest of the day. Bye-bye.
Likewise. Bye-bye.